Hello everyone. So continuing with the series of chest x-ray basics, in the previous videos we have discussed about a normal anatomy seen in a chest x-ray, and then we have discussed about pleural effusion. So today we will be discussing few important x-rays pertaining to collapse and consolidation. Important x-rays. So we have discussed all this. So now we will start off with pneumonia, right? So pneumonia is primarily of three types. Lobar pneumonia, this is the commonly given X-ray, bronchopneumonia and interstitial pneumonia, out of which the findings of interstitial pneumonia are mostly seen or better appreciated on a HRCT of the thorax. So it is not really appreciated in the chest X-ray, hence this will not be discussed. Out of lobar pneumonia and bronchopneumonia, lobar pneumonia is very much commonly asked in the exam. So what is the basic difference between the two? The primary location of the pathology, if it is in the alveoli, it is lobar pneumonia, meaning pertaining to certain lobes of the lung. If it starts from the bronchi, eventually it might happen that the pathology uh, will overlap at some point of time, but initially, to start off with, it will start off from the bronchi, that is the airways. This is bronchopneumonia. So primary location of the infection. So if it is respecting lobar boundaries, that is lobar pneumonia, so you will be finding dense consolidation and air bronchogram sign. But in bronchopneumonia, if it is predominantly involving the bronchi, that is the airways, then there will be patchy opacity. If it later on extends to the alveoli, you will be finding some air bronchograms also, but air bronchogram is typical for lobar pneumonia, for lobar consolidation. Now, and why this is important, why understanding the patterns of X-ray is important, because the treatment protocol will entirely be different for lobar pneumonia and the bronchopneumonia, because the organisms also differ greatly, right? And so now, what is air bronchogram? We will be seeing that on an X-ray, but let us see what is an air bronchogram, right? So let us say that these are my alveoli, thin walled sac alveoli, multiple in number, in and this is the respiratory bronchiole, right? And there will be other segments of bronchi also. And now in pneumonia, there is exudate exactly at this point and in the alveolar sacs. So there are multiple of them. So these are forming some consolidated thing that is appreciated on the X-ray. But notice that the airway, this are relatively free of any exudate. So against a so air looks black on X-ray, and if it is black on X-ray, it will be seen as a black thing against a white background. And what is the white background? That is all this opacity formed by your exudates in the alveoli. So it will look something like this. This is your bronchi in different cut section, and against the white background you will be finding something like this. So this entire thing will be surrounded by opacity. I'm drawing it in black, right? There is opacity everywhere, but the bronchus is relatively free. The bronchi and the bronchioles are relatively free, so it will be seen that is air inside the bronchi, that is air bronchogram. So that is it, and it is very suggestive of consolidation. Now let us look at the lobar anatomy first, and then go to the pathology. So from the frontal view, from the PA view, you can appreciate three lobes on the right side and two lobes on the left side. Predominantly, there are two fissures on the right, that is the horizontal fissure and the oblique fissure, dividing into three lobes of the right lung. And there is only oblique fissure here, but no horizontal fissure. So there are left upper lobe and left lower lobe. This is right middle lobe and right upper lobe, and this is a small part of right lower lobe. So what do you make of this X-ray, of this animated image? Is that the lower lobes cannot be seen much from the front side. Even during your examination, during your clinical examination, we do not get much of the lower lobe from the anterior side. To access the lower lobe, we need to go to the posterior side and then percuss and then auscultate. So predominantly we are having the right upper lobe, right middle lobe, left upper lobe and left lower lobe. So corresponding of right middle lobe, here we have something known as the lingular lobe, which is a part of the left upper lobe. This is the basic anatomy. Let us review that the same thing in the lateral X-ray film. This is usually not asked in the exam, but for the purpose of understanding, you see that this big fissure is the oblique fissure and this thing is the horizontal fissure. This is the right upper lobe, this is the right middle lobe, and this is the right lower lobe, and this is the posterior side, this is the anterior side. So you see that to access the lower lobe, it is predominantly in the posterior aspect. And similar thing on this side also. This is the oblique fissure dividing into the left upper lobe and the left lower lobe. It is predominantly a posterior thing, so it is seen like this on the lateral view of the X-ray. This is left lateral view and this is right lateral view. Right. With that, we have studied the air bronchogram here also. I am deleting this. So, right. Can we see these X-rays, and now we are in a better position to appreciate the consolidation. You see that this is a PA view, definitely this is a PA view, and the angles are clear, fine. The trachea is deviated somewhat to the right, but probably of some rotation component. But notice this pathology here. At the level of your hilum, at the level of the hilum, this is the horizontal fissure. This is the horizontal fissure. So above it is the right upper lobe. And somewhere here will be your oblique fissure, and this is the right middle lobe. Can you see that the horizontal fissure is at the same position where it should be? And this is a homogeneous opacity in the right upper zone. We cannot say it as a lobe. So it is a right upper zone homogeneous opacity. Are you following this? Homogeneous opacity. This is the right upper zone homogeneous opacity. If we zoom, there are certain air bronchograms seen inside the consolidation, inside this opacity. So this is the trachea is in the midline. The angles are free. There is no volume loss on this side. So this is not a collapse. This is a consolidation. So this is a right upper zone, right? Right upper zone consolidation. Let us see this image. So what do you make of it? We can see that the trachea is in the midline. The angles are clear. These angles are clear. Now the right heart border, you can see the right heart border here completely, but can you see there is some opacity obscuring the right heart border? Yes, there is certain opacity, and this is the your air bronchogram, that is the air filled bronchi against a wide opacity. So this is you cannot delineate this right heart border. So this is the right middle zone because it comes somewhere here. So it is the right middle zone consolidation. So these are all radiological terms, consolidation and the zone. We say it like that. So the homogeneous opacity, number one, no volume loss on the right side, no tracheal shift, no change in the diaphragmatic position. there is presence of air bronchogram, and that makes the diagnosis of a consolidation. This is the right middle lobe consolidation. Right. Let us see this X-ray again. So can you now delineate the right heart border? Yes. Unlike this, we were not seeing this right heart border. So basically, while describing or while detecting consolidation collapse on an X-ray, you need to exploit the Silhouette sign. We will be seeing that, but first of all, see this. These are air bronchogram. I'm deleting the arrows for you. These are air bronchogram inside a patch, inside a almost a homogeneous opacity. We can see air-filled bronchi, and it is in the which zone? It is in the right middle zone. It is in the right middle zone. But can you say which lobe it has, which lobe it is affecting? So it is the right upper lobe, because the right heart border is not obscured. That is, but in this X-ray you can see that the right heart border has been obliterated or not properly seen. It is because it is the Silhouette sign that we are talking about, that if a opacity lies in front of an object, you cannot see that thing properly on X-ray. So if a right middle lobe which overlies the right side of the heart, right border of the heart, if it is right middle lobe is filled with exudates, you cannot see the right border of the heart, but you can clearly see the right border of the heart. So it is a right upper zone pneumonia. See this X-ray, right? See this X-ray. Can you see the diaphragm on this side? This side diaphragm is properly seen, but this side diaphragm is not at all visible. There is a homogeneous opacity, right? And on searching we can find some fine air bronchogram, although not properly visible. There are some air bronchogram. Trachea is in the midline. There is some sort of rotation, but there is no volume loss on this side, right? So this is a right lower zone consolidation. Definitely it is in this part of the lung, right middle and the lower zone. But which lobe? Because the diaphragm is not being seen properly, it is a right lower lobe consolidation. We need two views for that, but exploiting the Silhouette sign, we can say this. In any X-ray anywhere in the body, we always need a two view of that organ or of that image of concern, because it is a 2D thing. The X-ray plate is a 2D thing. We cannot appreciate the exact location of a pathology unless two views are given to us. So mostly we are given this PA view, so we are discussing that. So is this clear by now? So now let us see the left side of the lung, which is predominantly occupied from the frontal aspect by the upper lobe, right? So can you say that if this left heart border is not properly seen, or if this descending thoracic aorta, if its border is not properly seen, can we say that there will be a right upper lobe consolidation? Let us see this image to know it, right? You can see that the heart border is properly seen, the angles are clear, the trachea is in the midline, but can you see this portion properly? The superior part of this hilum, it is not being visible. The descending aorta, initial part of the descending aorta is not being very much visible. There is opacity here. Now whether this is collapse or consolidation, the trachea is in the midline. The volume of this lung is comparable to this lung. Diaphragm are in the same position, right? And there are air bronchogram signs seen inside this relatively homogeneous opacity. So this is a left upper zone consolidation. And precisely if we want to say which lobe, It is left upper lobe consolidation. Yes. Let us see this X-ray. This is the superior part of the right upper lobe is relatively free, but this is opacity. Now, which lobe, if I want to say, you can see that the air bronchogram is being seen properly here. This is the part of air bronchogram. This is a relatively homogeneous opacity, but can you identify the left heart border? You cannot really identify the left heart border like you can do that in this X-ray, in this X-ray, but this X-ray you can see that there is a haziness of the left heart border. So the pathology is in the lingular lobe and partly in the upper lobe, the superior parts of the upper lobe also. So this is a left lingular lobe consolidation. Why consolidation? Why not collapse? Because air bronchogram is seen, trachea is in the midline, angles are clear, there is no signs of volume loss. So these are the findings. Every time you are given a consolidation, the important DD of consolidation is your collapse. Every time you are given this X-ray, you will be asked that whether it is a collapse or consolidation. Right. Now this is also another X-ray obscuring the left heart border. Can you see? The left heart border is not properly seen. There is air bronchogram, and so this is a left lingular lobe consolidation. Right. So this is the part of the lower lobe that is properly seen from really a small part of the lower lobe. Majority of it is seen in the lateral X-ray because it is a posteriorly located structure. Now you see this X-ray. There is an opacity, right, in the in the left middle zone and the left lower zone, I agree. But is it in the lingular lobe? No. You can see the left heart border. Yes or no? You can see the left heart border. But wait, where is the diaphragm? You cannot appreciate the diaphragmatic border. This is an X-ray of poor quality, I agree, but still you can see the diaphragm on the right side, but where is the diaphragm on the left side? Now contrast that with your previous X-rays. You can see the diaphragm here. The diaphragm is clearly visible. The opacity is so big, but the diaphragm is clearly visible. So this is a left lower lobe consolidation. We need two views to call it a left lower lobe, but still we can see that. So this is all about the Silhouette sign, very important sign in radiology, especially when it comes to X-rays. And so this is the loss of the normally visible border of an intrathoracic structure caused by an adjacent pulmonary density. So if a structure if a structure overlies another structure, you cannot see the posterior structure. That is the basic concept. So right upper lobe, if a opacity is there in the right upper lobe, you cannot see this ascending aorta. This is the ascending aorta. This is the descending, the aortic arch. You cannot see this part, right? That is the right upper lobe. If it is in the right middle lobe, you cannot see the right heart border. You cannot see the right heart border. Right diaphragm is obscured by opacities in the right lower lobe. Similarly in the left upper lobe, the aortic knob and the left heart border cannot be properly seen because here lies the lingula and this is the upper lobe. Definitely part of the upper lobe is lingula, and now the left diaphragm and the descending part of the thoracic aorta is obscured if a pathology is in the left lower lobe. So you can see that in this X-ray, where is the left heart border? Can we see the left heart border? No, the angles are clear. The trachea is in the midline. There is no volume loss as compared to the right, but there are presence of air bronchogram, and now we can this X-ray qualifies to be a lingular opacity because the left heart border is not clearly seen. You can specify that. If you say it is a left upper lobe opacity, then also you are right, but to be specific, lingula, because here lies the lingula, right? So now we have studied almost everything about lobar pneumonia. Now let us see few x-rays of bronchopneumonia. So these are patchy opacities, like I said, they do not respect lobar boundaries, mostly caused by atypical organisms. And if the area has been consolidated, you can find some air bronchogram, that's completely fine, but mostly it's a patchy opacity. It is a bilateral thing mostly. So this is a bronchopneumonia, X-ray of bronchopneumonia, patchy opacities involving the bronchi. Right. This is another X-ray. The trachea is almost in the midline. There is some component of rotation. Angles are clear, but see this part, you can see that the right heart border is not properly seen. So mostly you don't have to say a lobe when it is a bronchopneumonia. It is mostly bilateral thing, but still it is predominantly involving the right middle lobe, because the right heart border is not properly seen. And definitely diaphragm is somewhat, diaphragmatic border is obscured. Here it is very clearly seen, here it is not seen. Patchy opacities both sides, and of course combine it with history. This is a case of bronchopneumonia. Right. Now moving on to collapse. So in collapse you will again be exploiting the Silhouette sign. So every time you are given an X-ray of consolidation, always contrast it with a collapse X-ray, you will be asked, and vice versa. That is the important point. Now you see that the right horizontal fissure was somewhere here, would have been somewhere here, but it is drawn upward. So there is volume loss as evidenced by the right horizontal fissure being pulled upward. And it is a homogeneous opacity. If we zoom in, there is no air bronchogram and trachea is pulled to this side, right? That is it. So this is a right upper lobe collapse. Right. See this X-ray. What do you see? The right heart border. Where is the right heart border? I cannot see. The trachea is pulled. Right? The trachea is pulled. There is opacity here. Where is the right heart border? We cannot see it, but the diaphragmatic border can be seen to some extent. And you see that there is a peak in the diaphragm, right? It is also, there is inferior pulmonary ligament which is being pulled, and this is the right middle lobe collapse. Right middle lobe collapse. You can see that there is some evidence of rib crowding also when compared with the left side. So how do I say that these are collapse? Important thing or important technical term to tell whenever you are thinking of collapse is a thing called volume loss, features of volume loss. So what are features of volume loss? So there is rib crowding. If you can see on one side, if there is presence of rib crowding, then see the hemidiaphragm positions, right? Hemidiaphragm will be lifted upward or towards the side of the collapse. See tracheal shift, tracheal pull to one side. Air bronchogram will not be seen. Tracheal pull to one side, rib crowding, features of volume loss, and of course the Silhouette sign. All this will make a diagnosis of collapse and not consolidation. Right. See this X-ray again. Right heart border is not properly being visualized. So this is again a right middle lobe collapse. Trachea is in the midline. There is some sort of blunting in the angle, probably a right pleural effusion, minimal pleural effusion. Now see this X-ray. Right. Trachea is shifted to this side, and there is a triangular like opacity and the diaphragm should have been here. The diaphragm is here. So it is the medial side of the diaphragm that is also not being visible. So this opacity is the right lower lobe collapse. How do I know that? The diaphragm can't be traced to its medial aspect. Right, and definitely this is a, and see this x-ray, this diaphragm is looking like this, the diaphragm is not looking like this. There is tracheal pull to your right side. See this x-ray also. Again, the diaphragmatic border is not clearly seen. Trachea is shifted to your right side. So this is again your right lower lobe collapse. No air bronchogram, opacity, homogeneous opacity. Right. Now let us come to the left side. I hope by now you are habituated in exploiting the cell outside. Very important in collapse and consolidation. Now this is the entire location of left upper lobe, right? You can see that the left hemidiaphragm is traceable, but it is lifted upwards. The right hemidiaphragm, well, the right hemidiaphragm is also problematic. You cannot trace the line, but you can see that this is the left hemidiaphragm lifted up. Usually because of the liver, the right should have been here, but the left is lifted up. And so there is definitely a volume loss on this side. Now this is a relatively homogeneous opacity, sort of a veil. It is not a exactly opaque thing, but you can see through and through it, but it is not also transparent. It is like a veil covering the entire upper zone, entire middle zone and the lower zone of the lung. So, and you cannot delineate the descending thoracic aorta, the aortic knob, and where is the left heart border? We cannot see anything. So this is the veil sign of left upper lobe collapse. Right. See this X-ray? Again, this dotted line represent where there should be the left heart border, but we cannot see that. The diaphragm is no doubt lifted and pulled, and this is a veil sign of left upper lobe collapse. If you want to say that this is the x-ray, and if you want, this is the same x-ray by the way, and if you want to say that there is some problem in the right diaphragm because the right lower lobe, because the right diaphragm is not properly seen, so you might be right. So there can be two pathologies in a same x-ray, well, but the idea is to sensitize you to the fact that the veil sign is applicable when you are discussing regarding a left upper lobe collapse. Rhyming with the veil sign is your sale sign for the left lower lobe collapse. So how do I know that this is the left lower lobe? See, the trachea is in the midline, sort of midline, but there is a triangular opacity which is retrocardiac. This is the left heart border. There is a opacity retrocardiac. You can see through the heart, but the hemidiaphragm is obscured. The left hemidiaphragm is obscured on this medial side. There is no air bronchogram, so this is a left lower zone, left lower lobe collapse, and it will be confirmed if you are asked that how do you know this is a left lower lobe. Every time the answer of confirmation of a lobe comes with a lateral view x-ray. Right, comes with a lateral view x-ray. Sale sign of the left lower lobe collapse. Now this is another x-ray. There are two x-rays. Right, let us see this. So what do you make of it? See, this is a artifact. This is a prosthesis. put in the thoracic spine, probably some fracture fixated, and this is a post-op patient. So what do you expect in a post-operative patient of orthopedics? Because the patient is lying on the bed, so if you have to see this peripheral clues. Because the patient is lying on the bed, so the posterior lobe, so the posterior, I mean the lower lobes of the lung are not getting expanded properly, and basal atelectasis is a very common feature of post-op patients, right? So how do I know which lobe? This is the left lower lobe collapse. Probably there is a component of consolidation also, because this is the air bronchogram seen clearly up to here. The diaphragm contour has been lost completely. So this is a left lower lobe collapse with consolidation. Right. So this is your important clue. So there can be dual pathologies, and also please keep on looking by the approach of A, B, C, D, E, F, and some lines and tubes and prosthesis. This should be your approach. So this is a post-op patient for you. So another X-ray of again collapse. Which lobe? You can pause this video and try guessing that yourself. So the trachea is somewhat pulled because the spines are in the midline, but the trachea is pulled to this side. There is volume loss. Definitely there is volume loss. Well, where is the diaphragm border? Where is the diaphragm border? We cannot see the diaphragmatic border. And there is a retrocardiac opacity. This is the retrocardiac opacity, right? This is the retrocardiac opacity. There is no air bronchogram inside the opacity. So this is not a consolidation. The hemidiaphragm is lost and there is volume loss. So this is again an X-ray of left lower lobe collapse. So every time you diagnose a patient with collapse or consolidation, you are going to exploit the Silhouette sign. Right. So let us see the Silhouette sign once again for revision. So the left diaphragm descending aorta, if obscured, the pathology is in the left lower lobe. Left upper lobe obscures the aortic knob and the left heart border, and if only the left heart border is obscured, then it is lingular pathology. Upper lobe ascending aorta, middle lobe the right heart border, right diaphragm obscured by the right lower lobe. And if there are additional features of volume loss on one side, so you will be terming that as collapse, so volume loss. So that was it for this video. Keep studying. Thank you.